Ortho injuries is all about the limbs and extremities and what can go wrong when you get injured. There's going to be a lot of things we cover in this lecture, so they're going to be covered in superficial detail because orthopedic injuries generally all follow the same pattern. I'm going to use fractures as the way to set this up, but it's going to be very similar, and once you get to only the joints like the knees, do things change. You'll see what I mean when we get there. Let's start off by talking about fractures. If anyone suffers an injury and you're worried about a fracture, we're talking about limbs now, what you want to do is get 2 x-rays at a minimum, perpendicular to each other, to get the best view. And someone who has a fracture typically tells you. It's not a surprise, right? There's going to be pain and swelling. You can't tell there's a fracture unless it's open, and an open fracture means the skin has been broken. And then as you deal with fractures, there's 2 ways you can fix them. You can take them to the operating room and do an open reduction, internal fixation, or you can simply do a casting. And the idea here is that if you cast somebody, you're just going to wrap up their leg or their arm and hope that the bones line up and fuse the right way as they heal. To do that, you have to have a closed wound with good approximation. If it's open, angular, comminuted, or anything that's not a clean break, you're going to have to take them to the operating room and open it up. And if they've broken skin, if you've got an open fracture, you're going to have to go to the operating room as an emergency for an emergency washout. Now with this in mind, pain after an injury, get x-rays, see a fracture, surgery, or casting, you can talk about each individual injury one at a time. We're going to start off with the shoulder. We're going to talk about anterior and posterior dislocations. So an anterior dislocation of the shoulder can occur in essentially any trauma. Tackle, wrestling, car accident, whatever. And as the shoulder dislocates forward, what will happen is that the shoulder will be in an abducted position and the arm will be externally rotated. That is like as though they're shaking hands. Abducted, external rotation. As though they are shaking hands. Because there is the axillary nerve near there, you might have deltoid paresthesias. Now if you see it, it's a clinical diagnosis. You can get an x-ray, but once you see it, you're going to relocate and sling. You just pop it back into place and then let them rest it. If you compare that to a posterior dislocation, which must have massive trauma, not any trauma will do it. This has got to be the huge car accident, pedestrian struck, thrown from a vehicle, or the things you should look for being either seizures or lightning strikes, where the muscle contracts with such a force that it's able to dislocate posteriorly. In this case, it's still abducted, but now internally rotated. It's so-called protecting wrist. Abducted, internal rotated. And it looks like they're keeping their arm up against their chest because it's been hurt. It's not the arm that's hurt, it's the shoulder. Same here, x-ray. Relocate and sling. If you move away from the shoulder, get down into the hands, there's a couple of things you can do here to the wrist. The first is a Colles fracture. A Colles fracture is going to be an old lady who falls with an outstretched wrist. Common in osteoporosis. So frail old ladies who fall outstretched wrist, they're going to fracture their radius and ulna. It's going to be dorsally displaced. Diagnose it with an x-ray and either cast or surgery. Other fractures that are going to occur in younger people are going to be the named fractures. Monteggia and Galeazia. In the first, the person is going to be blocking upward from a downward blow, as though someone is blocking a police baton trying to protect their face, or a baseball bat or a crowbar. The thing strikes the ulna, breaking the ulna and displacing the radius. Upward block, downward blow. The ulna breaks, the radius dislocates. Surgery versus cast. In the other, the radius is going to be hit first. Same thing, police baton coming down on an arm that's out to the side. The radius takes the blow and breaks. The ulna dislocates. It's a downward block of an upward blow. The same thing happens in people who are trying to block a kick. As long as the radius is hit first, you're going to break the radius, displace the ulna. Diagnose it with an x-ray. Surgery versus cast. And then if we move down into the hand, you're going to have two diseases, scaphoid fracture and a boxer's fracture. The scaphoid has a tenuous vascular supply, so if you accidentally hurt that bone, the rest of it can become necrosed. So when someone has a fall on an outstretched hand, not an old lady, and then complains of pain at the anatomic snuff box, that's the space right here between the two tendons. If you got pain right there after you fall, you got a scaphoid fracture. And here's the thing, because it's a fracture, you're going to get an x-ray. And the x-ray is going to be normal on day one. Now if you see the fracture, great. But most of the time you don't see the fracture, but it's there anyway, and the vascular supply has been compromised. And so the part distal to the vascular supply is actually going to necrose and cause a lot of pain. So what you should do is cast it anyway. Because you come in a couple days later and repeat the x-ray, it turns positive. And you're glad you casted them because now you're fixing the fracture. The boxer's fracture is so called because it's what happened when someone makes a punch and hits the wrong thing. If someone punches a wall the wrong way or goes for someone's face and misses, the thing that's going to break are the weak fingers, especially the ones that you hit there first. So a boxer's fracture is a punch against the wall where the fourth and fifth digits break. So you can see there's not that whole much you have to know, but these little details do come in when you start looking at vignettes. This is the upper body. Let's change gears and talk about the legs. And we're going to start with the hip. It's important to know that knee pain can be referred hip pain. So if the knee hurts and is not swollen, it's probably the hip. If the knee hurts and it's swollen, it's probably the knee. So if someone suffers hip pathology, it may present as knee pain. The first of these diseases we're going to talk about is a hip fracture. You either need a lot of trauma or be the old lady with osteoporosis. In any case, if you break the hip, your leg is going to be shortened and externally rotated. When you have a hip fracture, what you want to do is make sure they've got intact pulses and sensation and motor distal to the injury. That's what you care about. The orthopodist is going to go in and fix it. And depending on where the fracture occurred is going to change what procedure they do. Now really, it's very difficult to break this down one-to-one because each surgery is going to be different based on the type of fracture and how bad it is. But what I want you to know for the main point of this is that the femoral head has a tenuous vascular supply, much like the scaphoid bone. So that, if you have a fracture of the femoral head, you're going to have to do a prosthesis. If it's an intratrochanteric fracture, you're going to use plates. If it involves the shaft, you're going to use rods. If it's open, it's emergency washout. And while you're transporting the patient, traction will help. It'll pull away the pieces of the bone grinding against each other. And then eventually it's going to be rehabilitation. That's the hip. Let's get to the knee. Lots can go on with the knee. And so first I want to start off with ACL and PCL injuries. Effectively the same thing. You have to have a locked leg and then for some sort of force. And if you take a hit from the front, the back's going to break. If you take a hit from the back, the front's going to break. So a posterior trauma will lead to an anterior ligament injury. If you've got an anterior ligament injury, you're going to have an anterior draw sign. That is where you have the person put their foot on the ground, bend their knee, and you pull on their calf. The ligament should hold it in place, and if you can draw it to you, it means the ACL is torn. If you push it away, normally it stays fixed in place. If you can push it farther than the other leg, the posterior ligament has been compromised. So an anterior trauma will give you a PCL injury and have a posterior draw sign. Now the knee, much unlike the bones of the leg and the arm, if you want information about the knee, you're going to need an MRI. Now you can do this by fixing it with surgery, and the people who get surgery are those who need to go back to work at their knee, and those are athletes. Everyone else just gets casting. This takes longer, but it's just as effective. This is everybody else. You got an ACL and a PCL. What about the laterals? The medial collateral ligament and the lateral collateral ligament can be injured as well. Now, varus, varus, what are those different words and what do they mean? Well, I only remember one because the letters line up, and it helps me then remember the other one is the other one, even though I don't remember what it's called. A valgus stress is a lateral stress. And as we learned from the ACL and PCL, if you have a lateral stress, you're going to injure the opposite side. That's an MCL injury. And then varus stress is the other one. So if someone takes a hit from the lateral side, it's going to injure the MCL, called a valgus stress. Again, it's the knee, so if you want to look at it, you get an MRI. And the people who get surgery right away are going to be those people who need to go back to work using their knee. Those are athletes. Everyone else gets a hinge cast. And lastly, let's not forget about the meniscus. I don't really know how this gets injured, but it does. And the patient is going to complain of knee pain and a click on extension. The diagnosis is made, an MRI, okay, it's the knee, and the treatment is arthroscopic repair. Every once in a while it needs to be removed, but you don't want to remove it because that can lead to osteoarthritis down the road. That's it from the knee. Let's move down to the shin. You can get a stress fracture. These are people who are going to be weekend warriors who aren't used to doing a lot of work with their foot or their leg, or those who go on forced marches. You do a lot of extra work than you're used to, and that weak bone then has a stress fracture. Stress because of the overuse and fracture because it's weak. It's not a super big break, it's really hard to identify. So your x-ray is probably going to be normal. If it shows a fracture, great, but chances are the x-ray is normal. And just like the scaphoid bone, you're going to cast anyway. Because you come back in a few days, all of a sudden the x-ray is positive. You certainly don't want to be walking around on this because that's how you got the injury in the first place. After you cast, you do crutches. And then also in the shin is the tib-fib fracture. The tibia is a big, strong bone. So if something breaks the tibia, the fibula is not going to be able to support the weight of the leg, so it's probably going to break too. So usually when you have one, you have the other. You can break the fibula on its own, especially if you get a side stripe trauma. But if it's bad enough to break the tibia, the fibula is probably going to break also. And the way you get it is going to be some pretty big trauma. So it's a fall from a height, or a lot of trauma directly to the side of the shin, as in a pedestrian struck. Has to be an adult because they're high enough up to take the blow to the leg. If this is a kid, they'd be hitting the chest or the head. You diagnose it on x-ray. You either cast or do surgery depending on how bad it is. All right, that's it for the shin. Let's round us out with the ankle and foot. Ankle fractures. So if you have over eversion or over inversion, you can cause an ankle fracture. But that's also how you sprain an ankle. So what you want to look for to say this is probably a fracture is a person who has that pain and swelling after an eversion or inversion and is non-ambulatory. If they can walk on their ankle, it is not broken. If they can walk on their ankle, they don't need an x-ray. If they're non-ambulatory and have pain and swelling, you get an x-ray to identify the fracture, and then you have to fix it. And that's generally going to be with surgery, because casting the ankle is weird and they usually don't break very well. Achilles tendon is the last injury that can happen to the ankle. And this is going to be the person who's going for a run. They hear a pop, then they limp. And when you reach back behind the ankle, there's actually a gap where the tendon should be. There's two ways to diagnose this. This is made clinically. You can cast it. This takes months to heal. Or you can do surgery. This takes weeks. And lastly, as we've been talking about all these things, one of the things that might come up that's not generally orthopedics, but involves the limb, is compartment syndrome. When you reperfuse ischemic tissue, whether it's a crush injury, an arterial embolism, whatever the case may be, as you reperfuse the tissue, you get edematous. And since there are fascial planes that maintain the compartments, if you get really tense in edematous, you can shut off the vascular supply to the distal extremity. So upon reperfusion, if the person then gets a really tense, painful leg, and it's like hard as a rock, you can check compartment pressures, and if they're elevated, simply do a fasciotomy. That way you relieve the pressure and return blood flow to the ischemic tissue. There's a lot of little things we talked about in this lecture, lots of little details, not a big picture. But generally what you want to look for is how bad is the fracture. If it's a bone you're looking at, it's an x-ray. If it's a joint you're looking at, it's an MRI. And if the fracture is really bad, you go to surgery right away. If the surgery is clean and well aligned, you can cast. Otherwise, it's those little details in each of these injuries that's going to tell you what the injury is, even if you can't see it. That's ortho injuries. Become a better doctor. Subscribe now to get access to our premium content.